The topic we are going to discuss will be on histiocytic and dendritic cell disorders. If you want to know this histiocytic and dendritic cell disorders, it's always important to understand where they originate from. So that is where you will be knowing the key to know what are the markers of these cells, because the markers play a very important role in understanding things. At the same time, the most important thing in this particular disorder will be the Langerhans cell histiocytosis, which is the highest yield for the exams as such. But other diseases like Rosai-Dorfman, HLH syndrome and all these things are not that important, but still it's better knowing for knowledge sake. But my emphasis in this entire video will be on the LCH, Langerhans cell histiocytosis. First, let us see where they are originating from. There are two things other. One is the histiocytes, and second one you have something called dendritic cells. If you ask me what are histiocytes, they are nothing but activated macrophages. Activated tissue macrophages. Obviously, activated macrophages means itself they are in the tissues only, which we know already. So they are activated tissue macrophages. This is what we are going to call it as histiocytes in a very simple term, even though many pathologists now think that histiocytes is complete transformation of macrophage into a different type of a cell. But right now, for simple understanding, we can know that histiocyte is nothing but an activated macrophage in the tissue. That's it. The most important thing is that you have to know that it is CD68 positive. This is a characteristic histiocyte marker. That CD68 will be the characteristic histiocyte marker. At the same time, they are originating from the myeloid, which means they are going to have myeloid lineage characteristic also. Like example, CD11C may be positive in these cells, but that is not important because CD68 is the most important histiocytic marker. And there are some disorders that are very important to understand. So what are the disorders or diseases associated with histiocytes? Number one, you have something called hemophagocytic lymphohistiocytosis or simply hemophagocytic syndrome, which we are going to discuss in detail. And second one, you have something called Rosai-Dorfman disease, RDD, otherwise referred to as something called sinus histiocytosis with massive lymphadenopathy. So then you have dendritic cells. Dendritic cells are a different group of cells, but still they will be grouped under something called professional antigen presenting cells. They are only two things will contribute to professional APCs. One is macrophages and dendritic cells. Obviously, dendritic cells are very important APCs. They present the antigens to the T cells. So coming on to the dendritic cells, what are the two different lineages of dendritic cells? So dendritic cell may originate from a myeloid lineage, or a dendritic cell can originate from a lymphoid lineage. So obviously you know very well. How will you know that the dendritic cell is originated from myeloid lineage? Because it will be CD11C positive. If it's originated from the lymphoid lineage, it must be CD11C negative, as simple as that. And a myeloid lineage dendritic cell again can be divided into two. One, those dendritic cells that are present in the stratified epithelium, in the stratified epithelial tissue, stratified epithelium. Second, those dendritic cells, those are present in the tissues except stratified epithelium. They are present in the tissues except the stratified epithelium. And the third type of dendritic cells are the ones that are found in the circulation, in the blood. So what are the stratified epithelium? Typically in the skin and the mucous membranes. Majority of the area, skin and the mucous membranes are the ones that are contributing to the stratified epithelium. So those dendritic cells that are seen in the stratified epithelium is what we refer to as Langerhans cells. Very, very important. And those dendritic cells that are present in the other tissues except the stratified epithelium, they are going to be called as interstitial dendritic cells. Interstitial dendritic cells. And those dendritic cells that are present in the circulation, we are going to call it as DC1. Or simply you can call it as myeloid dendritic cells. Other name, they are equatable. You can see myeloid dendritic cells are also called MDC. But those that are present in the circulation are also sometimes interchangeably referred to as something called myeloid dendritic cells. How will you differentiate? Obviously, the stratified epithelial Langerhans cells will be characteristically CD1A positive, and when you see these cells in electron microscopy, they are going to show characteristic tennis racket shaped granules. This is what we refer to as something called Birbeck granules. Obviously, they will be characteristically something like tennis racket shaped granules. This is what we refer to as Birbeck granules. It's a very characteristic feature. These two things, CD1A positivity and Birbeck granules, are very characteristic of Langerhans cells. But these two, you will not see CD1A nor you will see the Birbeck granule. So these type of dendritic cells. So these are we differentiate CD1A positivity and CD1A negative, which means the interstitial dendritic cells and the DC1 cells will be typically CD1A negative. And if you ask me what are the lymphoid dendritic cells, lymphoid dendritic cells are also referred to as plasmacytoid dendritic cells. Why they are called as plasmacytoid dendritic cells, or you can call it as PDCs? Why they are called plasmacytoid dendritic cells? Because they resemble plasma cells. Because they are going to resemble plasma cells. That is the reason why they will be called as plasmacytoid dendritic cells. If you ask me what is the function of this plasmacytoid dendritic cells, plasmacytoid dendritic cells are very, very important in one function, that is they are going to secrete a major interferon, that is a type 1 interferon, which is also referred to as something called interferon alpha. Interferon alpha. They are going to produce a large amount of interferon alpha. That is the reason why these are factories of interferon alpha. That is the reason why previously these plasmacytoid dendritic cells are also called as interferon producing cells, otherwise called as IPCs in the prior era. But right now we don't call that name, but anyway it's a plasmacytoid dendritic cell. Only one thing that, and again the plasmacytoid dendritic cells is not seen in the tissues, rather it will be seen in the circulation, not in the tissues. One very, very important thing about this plasmacytoid dendritic cell is because it is associated with SLE. There only it's important, systemic lupus erythematosus. In the current advancement, in the modern era, if you ask me, what is the key cell that is involved in the pathogenesis of SLE, I will tell you it's plasmacytoid dendritic cell. And what is the key molecular component in SLE, I will tell you it is interferon alpha. Interferon alpha is considered as the genetic and the molecular signature of SLE. We will be discussing a lot in detail in SLE actually. But apart from that, what are the disorders that are associated? I told you plasmacytoid SLE is the most important disease. Apart from that, if you ask me Langerhans cell, the most important disorder that will be associated with Langerhans cells is Langerhans cell histiocytosis, LCH. And there are certain disorders that are associated with your interstitial dendritic cells also. There are two diseases. Number one is something called juvenile xanthogranuloma, that is called JXG. And second one, you have something called Erdheim-Chester disease. Erdheim-Chester disease. These are the two things that are associated with your interstitial dendritic cells, because these are actually considered to be interstitial cell neoplasm. Juvenile xanthogranuloma, JXG, and Erdheim-Chester disease. So these are the general broad classification of dendritic cell and histiocytic cell disorders. But in that, the first thing, my key discussion will be on the LCH only. But right now, let us see what do you mean by HLH and Rosa-Dorfman disease. First, let us discuss on HLH, hemophagocytic lymphohistiocytosis. Hemophagocytic lymphohistiocytosis. What do you mean by HLH? It is that nothing but the histiocytes in the bone marrow is going to phagocytose their own fellow colleagues. That is nothing but the blood forming cells, the RBCs, WBCs, and their stem cells. All these things will be phagocytosed by the histiocytes in the bone marrow. So this is what we refer to as something called hemophagocytic lymphohistiocytosis, which is going to result in cytopenias. In fact, even sometimes a pancytopenia as well. So what is the pathogenesis? Pathogenesis is nothing but the activation of the histiocytes. That is what the basic pathophysiology. Activation of the histiocytes forms the key component. At the same time, not only histiocytes will be activated, there will be activation of the NK cells as well as the CD8 T killer cells also, which means all are cells that are going to kill the other cells. So CD8 T killer cells, NK cells, all these things will be activated along with histiocytes. So there will be a massive cytokine storm, which will result in secretion of lot of cytokines like interleukin 6, interleukin 10, interleukin 12. Then you have a soluble IL-2 receptor and interferon gamma. Among all this, the most important key element is the interferon gamma plus maybe a soluble interleukin 2 receptor. These are two things that are important for HLH pathophysiology. Apart from that, remaining to an extent you can forget. But soluble IL-2 receptor and interferon gamma are very, very important interleukins for HLH. So hemophagocytic lymphohistiocytosis. And what is the etiology? HLH is potentially a very dangerous. It could be a primary event or it could be a secondary event due to some underlying infection. But in general, HLH itself is a very, very dangerous thing. Like it can lead to multi-organ dysfunction and death also. But let us see, how will you diagnose HLH? Criteria for diagnosing HLH, or what are the cause etiology? First, what will be the etiology of HLH? Etiology of HLH we can classify into two. One is you have an inherited variety, and the second one you have something called an acquired variety of HLH. Inherited variety could be two types. One is familial HLH, and second one you have something called immunodeficiency or immune deficiency associated HLH. In the familial variety, usually there are two key enzymes other. One is called perforin and second is granzyme. These two enzymes are very, very important for killing the other cell by NK cells and CD8 T killer cells. So cytotoxic CD8 T killer cells and NK cells kill the other cells by virtue of two important enzymes, that is called granzyme and perforin. There are many other mechanisms other, but these two enzymes are also playing a vital role in killing of the other cells. So that is the reason why I told you these two enzymes. What is the reason why I am telling you here is because in familial HLH, the problem is in the genes that are regulating the secretion of or synthesis of your perforins and granzymes. Secretion synthesis of perforins and granzymes may be defective, and that is supposed to be the reason for developing this familial HLH. So what are the genes? Genes may be PRF1, this is a perforin 1 gene, and this is supposed to be the most important among the familial HLH variety. And second one, you have UNC13D, then you have STX11, then you have STXBP2. All these are genes, but as far as I know, the most important will be the PRF1 gene. Multiple times asked question, is this related to familial HLH, perforin 1 gene. Then immune deficiency associated, many syndromes are there, none of which is important for exams. You have something called, but I will write for the namesake. You have Griscelli syndrome, then you have Chediak-Higashi syndrome, then you have chronic granulomatous disease, then you have CD27 deficiency, then you have something called X-Men disease, then you have Hymansky-Podolak syndrome, X-linked lymphoproliferative disorder, Hymansky-Podolak syndrome, which is associated with IBD as well. So a lot of these syndromes may be associated with the inherited forms of HLH. And acquired forms of HLH are the most important because this is the most common variety, acquired forms of HLH, and it's the one that is going to happen in adults as well, very common. And if you ask me about the inherited forms of HLH will happen only in children usually, that too less than 3 years of age, not in more than 3 years of age. Children, infants less than 3 years of age, that's where you get, and it's very, very less common. Inherited variety can be due to infections, or can be due to autoimmune, or can be due to malignant process. But one catch that you have to know here is if it is happening due to autoimmune disorder, that is not called as HLH. Instead, the same HLH picture will be called as macrophage activation syndrome, which means the same HLH-like picture, if it happens in association with an autoimmune disease like rheumatoid arthritis or SLE, we are going to call that as macrophage activation syndrome and not HLH. Infection, lot of infections are there. For example, viral infections can cause, or bacterial infections can cause. If you ask me what viral infections, it could be due to HHV8, it could be due to HIV, it could be due to CMV, it could be due to EBV. So many viruses are there. Even parvovirus, but very important is EBV and CMV are considered to be the most important reasons for developing a HLH or hemophagocytic lymphohistiocytosis. Bacterial infections, as far as the most common will be, the most important will be the TB. I will not tell the most common because we don't have sufficient data to tell which is more common. But TB is the most important because I myself seen like 7 to 10 cases of TB related HLH, which is absolute gold. So to know that TB, a lot of patients that come with HLH, it could be leishmania, can cause, even typhoid, enteric fever can cause, a lot of things can cause HLH. On parasitical infection, malaria also can result in HLH. There are some case reports I have not seen personally, but a lot of case reports that show that malaria can also produce HLH. So these are malignant process, means usually the lymphoproliferative disorders, leukemias, lymphomas, these are the ones that regularly cause HLH like picture. So these are the etiology of HLH. And how will you diagnose HLH? You have a criteria, set criteria to diagnose HLH. What are the set criteria to diagnose HLH? Number one, you have three groups of criteria. One is the clinical criteria, second one is the laboratory criteria, and third one is the histological criteria. Clinically, only two things. One, the patient will be suffering from fever and that will be persistent for at least more than 7 days. And second one, the patient will have splenomegaly according to the criteria, but according to me, they will have hepatosplenomegaly rather than splenomegaly alone. And the lab criteria, if you ask me, lab criteria, first one will be the most important, cytopenias. Not only like simple anemia cannot tell you it's an HLH, at least there should be two lineages should be having cytopenia, like RBC and WBC or WBC and platelets, or platelets and RBC. Either minimum two lineages there should be cytopenia. Second, there will be high triglyceride, at least by definition more than 265 milligrams per deciliter, or a low fibrinogen, by definition at least less than 150 milligrams per deciliter. Number three, you will have a very high ferritin. By definition, it should be more than 500, but I have seen levels up to 30,000-40,000 also. Number four, there will be reduced NK cell activity, even though it is given in the criteria, but it's very difficult to find out in real practice. And fifth one, another one which is very difficult to find in real practice, is very high levels of soluble interleukin-2 receptor in the blood. That is nothing but CD25. So again, this is very difficult to find. These two are very difficult to find out in real practice, but other things you can find it out easily. Histological criteria, you have to prove there should be evidence of hemophagocytosis, which means you should show in biopsy of the bone marrow that one cell is engulfing the other cell, that is histiocytes are engulfing the other cells. So these are the things. You have 1, 2 overall, then 5, 7, 5 here and 7, and this one is the 8 finally. So if you have at least 5 out of 8 criteria matching, you can diagnose HLH as the possibility. So this is the criteria for diagnosing HLH. Very easy to find out. And if you want to know ever what you mean by hemophagocytosis, let us see on the slide. You can see here, this is what you mean by hemophagocytosis. You can see a histiocyte, a big one, which has engulfed a lot of other cells, like even WBCs, their precursors, RBCs, their precursors. It's killing and swallowing and digesting everything. So this is the typical picture of HLH. Hemophagocytosis, lymphohistiocytosis, because you need to differentiate this from another disorder called emperipolysis, which we'll discuss in some time. But this is a very important thing. It's absolute good. And now, what is the treatment of HLH? Treatment of HLH, most of the time, treatment of underlying cause, secondary cause, which means if the patient is suffering from HIV, treat the HIV. Patient is suffering from TB, treat the TB. Suffering from enteric fever and causing HLH, treat the enteric fever. Your things will resolve. If there is no resolution after treating the primary cause, or if the patient is having some idiopathic variety or primary variety of HLH where you suspecting inherited or congenital cause, or if there is no improvement with your routine treatment of the underlying cause, then you can go for other things like steroids. You can go for steroids plus etoposide. Steroids with etoposide. Typically, we'll use dexamethasone for this purpose. Steroids with etoposide. This is another option. All this thing I'll be writing plus or minus because this is not the very important treatment. For primary familial inherited varieties, this is okay, but for that is a secondary cause, these things are not that important unless until you don't have a good response at all. So steroids and etoposide, this is what we refer to as HLH94 protocol. Or you can add, along with it, you can add cyclosporin. If you have all these three things, that steroids, etoposide and cyclosporin together, we are going to call it as HLH 2004 criteria or HLH 2004 protocol. But what is preferred by many practitioners is the HLH 94 protocol. That's what we prefer rather than going for the HLH 2004 protocol. So this is what we are going to do. Apart from that, there are a lot of other treatment options are also there. Other treatment options include, you have rituximab, which is an anti-CD20 monoclonal antibody. Then you have alemtuzumab, which is an anti-CD52 monoclonal antibody. Then you have emapalumab, which is actually a very important monoclonal antibody against a very important cytokine of HLH, that is interferon gamma. So these are the other treatments that are available for treatment of HLH options, but most of the time just treating the underlying cause in adults will result in cure of HLH. That's enough most of the times. So we have discussed on HLH. Now we have to discuss a second histiocytic disorder, that is nothing but Rosai-Dorfman disease, or that's what I wrote in short form called RDD, Rosai-Dorfman disease. Rosai-Dorfman disease, or you all can also call this disorder as sinus histiocytosis. Sinus histiocytosis with massive lymphadenopathy. Sinus histiocytosis with massive lymphadenopathy. That's what you can do. So Rosai-Dorfman disease wise, if you ask me how the patient will present, patient will typically present with massive cervical lymphadenopathy. This is the usual area where the patient will have lymphadenopathy, and this cervical lymphadenopathies often tend to be massive, and that's how the patient really comes, massive lymphadenopathy. That's why it's called sinus histiocytosis with massive lymphadenopathy. They'll have a massive cervical lymph node. Obviously, you cannot diagnose based on other things. You have to take a biopsy of this lymph node. The biopsy is what is going to be the diagnostic key. The biopsy, what you will see typically is that you will see histiocytes that are increased in number, and they'll be located within the lymph node sinus. And these non-malignant proliferation, this is not a malignant proliferation, this is non-malignant proliferation of histiocytes within sinuses of the lymph nodes. So that is why it's called sinus histiocytosis with massive lymphadenopathy. That is what we call Rosai-Dorfman disease. Typically, you know very well the features of these histiocytes. They definitely must be CD68 positive. They should be S100 positive. At the same time, they should be CD1A negative, because CD1A positivity will go towards Langerhans cell, that's a dendritic cell. But here CD1A negative, but the patient will have CD68 positive, it's a catalytic histiocyte marker, and S100 positive, again it's likely to be a histiocyte and dendritic cell marker. So this is how it's going to work. So these are the biopsy of the lymph node that you are going to see in this patient. So the next thing what you can know is the treatment of this Rosai-Dorfman disease. Treatment of Rosai-Dorfman disease is typically steroids to reduce the proliferation of the histiocytes, plus or minus you can add something called a clofarabine. Clofarabine, suppose very rare instances, it can involve the bone and the orbit. For bone and the orbit lesions, you can use this clofarabine, but apart from that, you're not going to use this clofarabine. Only steroids are more than enough most of the times. And Rosai-Dorfman disease may also have other features like leukocytosis, elevated erythrocyte segmentation rate, hyper gamma globulinemia, which will be typically polyclonal, and patient may have anemia. All these things are also possible in Rosai-Dorfman. But remember, typical exam scenario, what you will get is the cervical lymphadenopathy, and they will tell you in biopsy you are seeing sinus histiocytosis, and the cells that are proliferating within the lymph node sinuses will be S100 and CD68 positive, that's CD1A negative. Typically in exam, you are going to diagnose this patient as having Rosai-Dorfman disease. That's it. The next disease is the most important one, what we are going to discuss, that is on the LCH, that is Langerhans cell histiocytosis. As we already discussed, this is the most important in this histiocytic and dendritic cell disorders, Langerhans cell histiocytosis. First of all, what you have to understand that this LCH is actually a malignancy because it's a clonal disorder. It's a clonal proliferation of Langerhans cell. Even though it should not be ideally called as histiocytosis, but still, okay, sometimes errors are allowed in medicine, so it's a Langerhans cell histiocytosis, but it's actually a dendritic cell disorder. It's a Langerhans cell is a dendritic cell, to be honest. So, but it's a clonal proliferation, that's what's very important, because single cell that is proliferating, clonal proliferation of Langerhans cells. Where you are going to see particularly is many times in exam there will be an infant in question will come with a skin lesion. This is how typically Langerhans cell histiocytosis will present. In a nutshell, overall in exam what they'll give is there will be an infant or a child who will be coming with skin lesion, some skin lesion, like typically the examiner loves to give a word called eczema that will be not responding to your routine treatment, not responding to the treatment given by a pediatrician or dermatologist, and you will take a biopsy, and in the biopsy you will see CD1A positive cells. These are nothing but Langerhans cells because they are CD1A positive. Plus or minus, the examiner may give bone lesions which are typically punched out lytic lesions. Plus or minus, the examiner may give bone lesions which are typically punched out lytic lesions. So these are the typical features of a Langerhans cell histiocytosis. cytosis. So this is how they give, but it is typically even more than this. That is what you have to see. Langerhans histiocytosis can be divided into two things. One is called, if you take an LCH and you can divide into a single system LCH, a single system Langerhans histiocytosis, or you can call it as a multiple system or a multi-system Langerhans histiocytosis or a multi-system LCH. If it's a single system LCH, and again in that one particular system what is involved, maybe skin or a bone or even a liver, whatever. If it's a single system LCH, you can divide into a unifocal, which means only one side of that particular system is involved, or it could be a multifocal. A classic example of a single system unifocal and single system multifocal is single system unifocal you can tell in like maybe in the bone where monostotic, only one area lytic lesion will be there, and a multifocal means multiple polyostotic, multiple areas in the bone will have lytic lesion. This is called multifocal, single system involved. Simple example I'm telling. If it's a multiple system, you can again divide into low risk areas and you can divide into high risk zones. Multiple system areas, multiple systems are involved, but if it's high risk means the three organs will go catastrophically for high risk multi-system involvement. That is, one is the bone marrow, or simply in books you will call it as a hematopoietic tissue involvement. Second one is the liver, and third one is the spleen. So these are the three areas which are generally called as high risk for LCH. If these three areas are involved, the prognosis is also going to be very poor. So these are how you classify LCH, typically whether it's a single system or a multi-system, single system unifocal or a multifocal, multi-system low risk or a high risk area. That's how it's going to behave like. And one more important thing is, in single system LCH, usually the patient will not have symptoms like fever and weight loss. These are typically B symptoms, but they don't have fever and weight loss. Whereas in multi-system involvement, the patient is going to have a fever and a weight loss. This fever and weight loss constitutional symptoms or B symptoms are very common in multi-system LCH compared to a single system LCH. So this is what is very, very important to understand. In general, the multiple system itself is going to have a little poor prognosis. At the same time, this high risk involvement has more poor prognosis compared to this low risk areas multi-system involvement. And if you ask me pathophysiology, because I didn't tell you this one particular point, pathophysiology of this Langerhans histiocytosis, most of the times the LCH pathophysiology revolves around the BRAF mutations. Typically in exam they will ask you this, but in one extra thing what you can remember is this V600E mutation. If you want, you can remember, or otherwise simply you can know that this BRAF mutation, which is a component of the RAS MAP kinase pathway, which is a cell proliferative pathway in pathology. So that protein mutation is what is very, very common in Langerhans histiocytosis. In fact, this presence of this mutation itself indicates a very severe disease and a poor prognosis. That's what you have to understand. Presence of this mutation itself is common. At the same time, presence of this mutation itself tells you that the patient will be having a poor prognosis and a more severe disease. So this is how you classify. Remember the prior classification of letter received disease, then you have something called Hand-Schüller-Christian disease, then eosinophilic granuloma, and all this classification has been abandoned by now. Instead, it's very simplified, very pleasant classification, that is a single system or a multi-system LCH, as simple as that as of now. So next thing, let us see what are the systems that might be involved. The first system is what I'm going to discuss is the bone. Bone is the most common system involved in Langerhans histiocytosis, where almost 80% of the patients will have some form of bone involvement, and the characteristic bone involvement is going to be the lytic lesions in the bone. That's what is going to be the characteristic involvement in Langerhans histiocytosis. Where in the bone, if you typically ask me, in the children, the most common bone involved is the skull, whereas in the adults, the most common bone involved is the jaw followed by the skull. So these two are very important to understand. Again, skull is the most common bone in children and jaw is the most common bone in adults. Both children and adults can have other bones also can be involved by like long bones like femur, long bones like humerus, then ribs, then vertebra. All these things can be involved in all these things can be involved in when the bone is getting involved. So next thing what you want to know is how they're going to present. The presentation is highly variable. The lytic lesion in the bone can be completely asymptomatic, or they can present with local pain and tenderness, or they can also present with a soft tissue swelling. That is also possible. soft tissue swelling. So typically they present with, most of the times will be asymptomatic only, or they can present with the local pain and swelling. And this is how adults usually present most of the time, because they come with some problems the bone, they tell, and that's how you diagnose the bone problems. And next organ to be involved is the skin. Skin is supposed to be the second most common organ to be involved, and this is very, very important for children, infant perspective, because children cannot complain bone lesions even if there is a local pain and tenderness most of the time, because the skin lesions are the one that brings the child to the pediatrician or to the dermatologist, pediatric dermatologist in the beginning. When they diagnose as eczema and they don't really respond to it, the treatment for eczema, and then they take a biopsy and they diagnose CD1A positive cells and they diagnose it's a Langerhans histiocytosis. So the most important thing is to understand that skin is very important for infants and children than adults, even though it's the second most common organ involved. It carries a huge importance for children, skin. And how the lesions will be. Skin lesions are going to be typically, like brown purplish papules. That's what I call. These are brown purplish papules. These brown purplish papules that are seen in children as a part of the skin lesion in LCH is what we called as something called self-healing reticulocytosis, or simply there is another name for that is also called as Hashimoto-Pritzker disease. That's also referred to as something called Hashimoto-Pritzker disease, or simply you can even call it as a self-healing reticulocytosis. This is how we're going to find, and this is very, very common in infants. At the same time, they can present as eczematous rashes also. I was telling about this eczema for a long time. Very common in children and adults, eczematous rashes, than in infants. Eczematous rashes are very common in children and adults. At the same time, especially in infants, many times this eczema, brownish papules, all these things may be even confused for seborrheic dermatitis. Many times, even if it happens in the scalp, you can confuse this for a seborrheic dermatitis, especially if it happens in the face, this area, scalp and all, you can even, they will be starting to treat as a seborrheic dermatitis. Other presentations, they can come with gingivitis, they can come with a mucosal ulceration, they will come with an intraoral mass. All these things are not important for you, but two very important words that you have to know for exams is the eczema, and second is the brown purplish papules. So these are the two things that are very important for understanding in exams. So next thing, so what are the other organs to be affected? Other organs to be affected will be the lymph nodes, only 20% incidence. Usual nodes that will be affected are the cervical group of nodes. They will be, consistency will be soft, and they common tend to be matted on palpation, like TB, tuberculosis. So this is one important thing to understand. So matted nodes doesn't mean only tuberculosis, it can also mean LCH sometimes in exams. And you have a hepatosplenomegaly, which means they are involving liver and spleen. In both these conditions, both these actually high risk organs, whenever liver and spleen are involved, that LCH is going to have a poor prognosis because they are high risk organs. So that thing you have to understand. At the same time, they might have an association with the PSC, that's called primary sclerosing cholangitis. Some patients may develop a sclerosing cholangitis picture also. So you have to know that also, along with the hepatosplenomegaly. Then we'll move on to the lung involvement. So what are going to be the lung involvement? Incidence is only 10%, the lung involvement. Usually it is smoking related, and the adults, usually seen in adults, and those who especially smoke, it's an exclusive smoking related, that is typically called as something called pulmonary LCH. I'm not going to discuss much here because I'm going to discuss in detail in the respiratory pulmonary medicine section, where something called a pulmonary Langerhans histiocytosis is considered as a part of an interstitial lung disease. Etiology of said ILD, that is smoking related ILD. There are many smoking related ILDs are there, like RBILD, then DIP, and one very, very important thing to understand is this pulmonary Langerhans histiocytosis is also a type of ILD that is smoking related in adults. Typically smoking related, only 10% is the incidence. So these are the important things. And next thing is the CNS involvement. CNS involvement is not that common, but if they ask you most common endocrine abnormality in Langerhans histiocytosis, answer will be diabetes insipidus. And these patients may also have associated proptosis because of the involvement of the soft tissues behind the orbit. So they can push the orbital eyeball outside the socket, and that might look like the patient is having a proptosis. Very important. So proptosis also can happen because of the CNS involvement. And G8 involvement is the least common system to be involved. So you can, children may present with diarrhea and malabsorption also. So this is how they present usually. So these are the things, but as far as I know, the most important are the 3 to 4 points are very important to understand here. The first point to know is that infants and children, adults who present with skin lesions, children, adults present with eczema, and infants are going to present with these brownish purplish lesions, which are very, very important. And the same time, second is the bone, where they present with punched out lytic skin lesions, and the third one is the lung involvement, especially in smokers, in adults. That is what we refer to as something called pulmonary Langerhans histiocytosis, which is typically seen in, which is typically classified under ILD in adults. So these are the very important things. And maybe one more important point will be the diabetes insipidus, that is very important in adult population. Diabetes insipidus in adults, which is also very, very important. There are, I'm going to also discuss on the previous classification system. That is not important, but still, since it's been asked traditionally exam, the previous classification systems also we can discuss. That is, one is called as letter-received disease. Letter-received disease. Second one, you have something called Hand-Schüller-Christian disease. Hand-Schüller-Christian disease. Hand-Schüller-Christian disease. And third one, you have something called an eosinophilic granuloma. Third one, you have something called a eosinophilic granuloma. So these are the 3 pictures that were old classification. Please do understand that these classification systems are outdated and we are not going to use it anymore. Just for the sake of exams, I'm discussing all these things. What do you mean by letter-received disease? Typically, it's like a fulminant disease. Usually, very young children, less than 2 years, will be affected, and it's one of the examples of multisystemic involvement, where usually you will get involvement of high-risk organs. High-risk organs like liver and the spleen, and the patient will have skin involvement very similar to seborrheic dermatitis, which I told you already. Skin involvement will be there, and the patient, most importantly, lytic skin lesions. Very commonly, the skull will be involved because it's a child. I told you, in the child, skull is the most common organ to be involved. So high-risk organ involvement like liver and spleen, skin involvement resembling seborrheic dermatitis, and lytic lesion in the skull, very typical. So this is what previously we thought, and we called it as letter-received disease. And the other name for this letter-received disease, we also call it as acute disseminated LCH, and they need very intensive chemotherapy, which we'll discuss in some time. So acute disseminated LCH, but these terms should be avoided. In the modern era, this letter-received disease will come under simply multisystemic LCH with high-risk organ involvement. That's it, nothing else. So that is how you're going to diagnose this in the modern era. But apart from that, previously in the old era, this was called as letter-received disease. What about Hand-Schüller-Christian disease? Hand-Schüller-Christian disease is very common in children. Again, usually it is diagnosed by a characteristic triad. One is the diabetes insipidus. I told you most common endocrine abnormality in LCH is diabetes insipidus. And second one, you have this lytic lesions, especially in the skull. And the third one, you have exophthalmos. I told you, they can present the exophthalmos because of orbital soft tissue involvement. So diabetes insipidus, exophthalmos, lytic lesions in the skull. So this is what we refer to as Hand-Schüller-Christian disease. And this Hand-Schüller-Christian disease, like your letter-received disease, has another additional name called as multifocal or multiple eosinophilic granuloma. Eosinophilic granuloma. Unlike your letter-received disease and acute disseminated STH, this multifocal eosinophilic granuloma may not need intensive therapy, and they may even go for spontaneous remission. That's what is given in the textbooks, but I don't believe because it's involving multi-systems. But one good thing is it's not involving the high-risk organs like liver and spleen. That is the reason why it's having a relatively good prognosis compared to letter-received disease. In the modern era, this can be put under multisystemic involvement with low risk. It's not high risk because your liver, spleen, bone marrow is not involved. So it's a low risk. So it might not need intensive therapy, and they may even go for spontaneous remission. You can understand the relationship as well. And eosinophilic granuloma, very common in adults. And again, most common organ involved in eosinophilic granuloma is the bone. Very simple, it's a single system. Only one thing is involved, that is the bone. That's it, nothing else. Because bone is the most common organ involved. This is old classification. That's why it's giving very primitive things. Most common organ involved will be the bone. In the bone, the most common area involved will be the skull or the jaw most of the times. And generally this have a very, very indolent course. Indolent in the sense this will not have an aggressive course at all. Just maybe a resection plus or minus a local radiotherapy is enough to cure this eosinophilic granuloma. Remember, one more thing I didn't tell you. When will you call an eosinophilic granuloma? Actually, this eosinophilic granuloma is a misnomer, number one. Because it is not due to eosinophils, it is due to histiocytes. I mean, histiocyte itself is a misnomer because they are due to actually dendritic cells, not actually histiocytes. It's a dendritic cell disorder. So it's a misnomer in the first place. This eosinophilic granuloma is a misnomer. And when will you call eosinophilic granuloma? As per the current understanding, if you have a single system disease, with if you have a unifocal involvement, a single focus is not unifocal involvement, this can also be called as a eosinophilic granuloma. Again, it's a misnomer because when you take a biopsy, that area will be having a lot of eosinophils. That's why they call it as an eosinophilic granuloma. But actually, it is the malignant cells are not the eosinophils; they are the histiocytes that are present there. That Langerhans cells that are present there. That is why actually it's the Langerhans cells tumor. That is the malignant cells there, not the eosinophils. Even though they appear to be increased in that area where the tumor is seen. So anyway, the eosinophilic granuloma name is a misnomer, and it can be applied to anything that is having a Langerhans cell histiocytosis, which is a single system unifocal disease. You can call it as a eosinophilic granuloma. That is why they would have told, when I am discussing a pulmonary Langerhans cell histiocytosis, which I will discuss in respiratory medicine, where in pulmonary Langerhans cell histiocytosis I will be grouped under a disease called ILD, where it typically affects the upper lobe. And it is actually, they will be having a single lesion, single solitary lesion in the upper lobe. And like it is exclusively seen in smokers. There also they would have given, it is called as eosinophilic granuloma, and they would have told it's a misnomer. Again, my general rule will apply here also, because even here you are seeing actually a single lesion, single system unifocal lesion, that is in the single system means it's seen only in the pulmonary region, that's the lung, and it's a single lesion. That is why single unifocal lesions, this is also referred to as eosinophilic granuloma, because many students think that eosinophilic granuloma means it's only the pulmonary Langerhans cell histiocytosis. No, it's not like that. Any single system unifocal single lesion, we are going to call it as a eosinophilic granuloma as per the terminology. But that name is a misnomer, so better avoid that and try to use the name called Langerhans cell histiocytosis. So these are some of the confusing things which I am trying to clear it off. That's all. Even though, remember very carefully, this letter-received Hand-Schüller-Christian disease and this eosinophilic granuloma, all these things are not currently in use. Even though just for the exam sake, I've told you all these things, but the only one thing that you have to know as per the current classification is this single system or multi-system involvement. That's it. So why? Because the treatment also is going to differ, because if it's going to be a single system involvement, you are going to do only very less intensive things, like you are going to do only resection, plus or minus you are going to give radiotherapy. That's all. If skin is involved, plus or minus, suppose if skin is involved, then you can give topical steroids. You can give topical steroids or PUA. That's called PUA therapy. That's also you can use. So if suppose skin is involved, so topical steroids and PUA therapy, that's called Soral and ultraviolet. You all know that, you have studied detail in dermatology. So if suppose skin is involved, you can give topical steroids or PUA therapy. If that is not the case, then most of the times only resection is enough. Maybe you can add it, plus or minus the radiotherapy may be sufficient. That's all. Less intensive therapy. That's what I'm trying to tell. If it's a multi-system involvement, you might be needing chemotherapy, and intensive treatment must be needed, especially if it's a high risk. Especially if it's a high risk disease, you might need to treat them with very intensive chemotherapy, like chemotherapy with vinblastine, that is vinca alkaloids. Along with that, you might be needing a methotrexate, also steroids, and 6-mercaptopurine. All these things might be needed if like you have a multi-system involvement, especially if you have a high-risk disease. So this is why we are classifying. So single system disease, you are going to treat only very less intensively with just a resection of the mass, plus or minus radiotherapy, plus or minus maybe topical steroids or poor therapy if your skin is involved. Multi-system involvement means you are going to treat with intensive chemotherapy like vinblastine, methotrexate, steroids, and 6-mercaptopurine. That's it. So how you are going to make a diagnosis of this Langerhans histiocytosis? Diagnosis of this Langerhans histiocytosis is typically based on biopsy only, because wherever you see a lesion, maybe a skin or the bone lesion, you're going to take a biopsy from that lesion, where in the biopsy you will be seeing some heterogeneous collection of, you will see a Langerhans cells along with lot of eosinophils in that area. Along with that, you will see histiocytes also. You will be seeing a lot of histiocytes also along with it. You will see a Langerhans cell, you will see eosinophils, you will see a lot of histiocytes also, and this presence of a huge collection of eosinophils in the tumor area, that is the reason why these tumors in the past are also called as eosinophilic granulomas, but right now be very clear, it will be called only as Langerhans cell histiocytosis. You are going to see all these collections, so that is why this is called as heterogeneous collection of cells. Different cells are going to be present, but the tumor cells here are typically the Langerhans cells only. So this is what the culprit is, and that is what is going to form the tumor here. And obviously you know that very well. This Langerhans cell has certain characteristics. The first thing in histopathology, in HND staining, if you see, you can see some characteristic appearance of the nucleus that is called as twisted towel appearance. Twisted towel appearance of the nucleus, or you can call it as a coffee bean appearance of the nucleus. This coffee bean appearance of the nucleus is not that specific for this. You can see in many other malignancies also, but this is given in the textbook. That's why coffee bean appearance of the nucleus or twisted towel appearance of the nucleus is very characteristic of these Langerhans cells. At the same time, when you do IHC, they will be CD1A positive, they will be S100 positive, and they will be CD207 positive. Please do remember these three markers. The CD207 is also referred to as something called Langerin. So these three markers are very, very characteristic. The most important and very commonly asked in exam is the CD1A, more than all these things. So please do remember this CD1A, which is characteristic a Langerhans cell marker. If the tumor cells are positive for the CD1A, it's a Langerhans cell tumor. That's all. And apart from that, in electron microscopy, they can have this Birbeck granules. They can have this Birbeck granules, which are typically tennis racket-like appearance. So this is what we refer to as something called Birbeck granules. So let us see the clinical features in a image-based form. You can see this is one image where you can see eczematous rash in the children, especially in the diaper area. Many times the mother can mistake it for a diaper rash, and that's how they commonly think it as an eczema and allergy, and they treat for it and it doesn't respond, and finally they take a biopsy and diagnose as Langerhans histiocytosis. These are typical eczematous lesions. I told you this also is one of the presentations which typically resembles like a seborrheic dermatitis. You can see these lesions are classically looking like a seborrheic dermatitis that like you commonly see in the OPD. So again, they treat for it, it doesn't respond, take a biopsy, you diagnose, it's Langerhans cell histiocytosis. And you can see these are multiple punched out lytic lesions. Previously, this image, when I was studying my undergraduation, post-graduation entrance, that time this image was supposed to be the image of letter-sieve disease, where you'll see multiple polyostotic punched out lesions in the skull along with the skin lesions resembling seborrheic dermatitis. Along with that, you will see this liver and spleen involvement. We call it a seborrheic, letter-sieve disease. But anyway, right now, this will not mean anything. It is just a polyostotic bone involvement. Along with if you have skin and other thing involvement, you can classify as a multi-stem or a single-stem disease. But anyway, these are the typical punched out lesions which you can see in child, in the skull, or even in the adults. That is characteristic of lesions of LCH. It can be seen in myeloma also. These are just lytic lesions in the skull, that's all. You can see another lytic lesion in the vertebral column. That is also one of the proven case of Langerhans cell histiocytosis. You can see in this guy, you can see proptosis of the left eye in this patient. And biopsy from the retroorbital mass like lesion after taking an MRI proved out to be this boy is also having a Langerhans cell histiocytosis, and this is the characteristic electron microscopic appearance where you are seeing this tennis racket shaped Birbeck granules. Distal dilation is not important actually, even though as per textbooks this is what is this racket shape. This is what is actually what I'm shading is what is more important, or I can show you one more time. This is what is very important. That is what we call tennis racket shape, and that is what is Bierbecke granule. This distal end dilation may be seen or may not be seen. For example, this particular thing, you are not even seeing a distal, that bulbar dilatation itself. So, but this is also Bierbecke granule only. Distal dilatation may be there or may not be there in electron microscopy. This is characteristic of Bierbecke granule. So this is on electron microscopy. So this is the thing we have discussed on Langerhans histiocytosis. But next thing, let us see what are the differences between a Langerhans histiocytosis and a Rosai-Dorfman disease. Langerhans histiocytosis and a Rosai-Dorfman disease. What you see typically, if you ask me the etiology, it is not known for both. It's idiopathic unknown etiology for both Langerhans histiocytosis as well as Rosai-Dorfman disease. Human herpes virus 6 association is again seen in both Langerhans histiocytosis and Rosai-Dorfman disease. And next thing, clinically, if you ask me about what are the features, two things we can tell. One is the skeletal involvement and second is the lymph node involvement. Skeletal involvement, yes, 80% of LCH case I told you already is having skeletal involvement, but less than 10%, which means skeletal involvement is going to be very rare in Rosai-Dorfman disease. Whereas lymph node involvement, 20% in case of like Langerhans histiocytosis, and more than 90%, almost near 100%. Almost all patients will have lymph node involvement. Typically, the cervical node enlargement, very classical. That's why it's called sinus histiocytosis with massive lymphadenopathy. So very common in Rosai-Dorfman disease. And next is extranodal involvement. Extranodal involvement is very, very common, especially the skin. I told you, very common skin bone lesions, very, very common in case of your Langerhans histiocytosis, very, very uncommon in case of Rosai-Dorfman disease. And what is the cell typically that is seen? Here it is a Langerhans cell that you will see. Here it is a non-Langerhans cell that you are seeing, which means a true histiocytic disorder. Rosai-Dorfman disease is a true histiocytic disorder. It's not a true histiocytic. It's actually a dendritic cell line. That's Langerhans cell. That's the tumor cell here. I can write tumor cell here. Tumor cell. And whether eosinophilia will be seen or not. Eosinophilia will be seen or not. Very common, especially on the site. Eosinophilia infiltration is very common in Langerhans histiocytosis. Usually you don't see. Very rare in case of a Rosai-Dorfman disease. And when you do an IHC, immunohistochemistry and immunostaining, I told you CD1A positive, S100 positive in case of Langerhans histiocytosis, whereas CD1A negative and S100 negative in case of Rosai-Dorfman disease. And finally, you have something called emperipolysis. Emperipolysis is not a feature of Langerhans histiocytosis, whereas it's a very common feature of Rosai-Dorfman disease. Actually, in exam, the moment you call emperipolysis, think about Rosai-Dorfman disease. This is the point for Rosai-Dorfman disease. Again, very important. I didn't tell you there, but I think I mentioned it. I'm not remembering exactly. But if you, in exam, if you want to remember one point about Rosai-Dorfman disease, think about emperipolysis. Similarly, if you want to know one single cause of emperipolysis, think about Rosai-Dorfman disease in exam. Very important point. So what do you mean by emperipolysis? Emperipolysis means you have a cell, and inside that, so you have a cell nucleus. Yes, you have a cell nucleus in that. And inside that cell, you have another intact cell with a nucleus and a cytoplasm. In the cytoplasm, you have another, in the cytoplasm of the cell. So this is the cytoplasm of the cell, maybe a macrophage or something. This is the nucleus of the cell. And you, inside that, you have another cell, completely another cell, which is completely intact as well. This is what we call emperipolysis. Remember, this might resemble a HLH. You might call why it is not hemophagocytosis. Remember, in HLH, the cell that is present within the, that is phagocytosed is actually killed in a HLH. But here, in emperipolysis, the cell that is swallowed by the neighboring cell or a nearby cell, inflammatory cell, is not killed. Is not killed. This cell is not killed. This is intact cell, living cell inside another cell. So this is what we refer to as emperipolysis. The cell is killed, that becomes hemophagocytosis. That is different. That's HLH. Cell is not killed here. It's just present inside another cell, and it's alive also. So this is what we refer, and it's not killed by any lysosomal enzymes. So that is what we called as emperipolis, very characteristic of Rosai-Dorfman disease. So if you ask me what are the conditions that can produce emperipolis, again very important for exams. First one that is important is, obviously I'm going to tell, the first thing is the Rosai-Dorfman disease, second one is the autoimmune hepatitis, relatively important. Third one you can see in MDS, myelodysplastic syndrome, you can see in myeloproliferative neoplasms like primary myelofibrosis or polycythemia vera or CML. Sometimes, rarely, you can see in many lymphomas, leukemias, lot of areas you can see this emperipolis. But if you ask me, the most important in exam, the moment they call emperipolis, you have to think about Rosai-Dorfman disease. Relatively important is the autoimmune hepatitis. But other things, it's your wish to remember or not to remember. That's it. So emperipolis, again, you can see in two areas. One, if the megakaryocytes engulf hematopoietic cells. The megakaryocytes can engulf the hematopoietic cells. The megakaryocytes engulf hematopoietic cells. So this is typically seen in lymphomas, leukemias, myelodysplastic syndrome, myeloproliferative neoplasms. In all these conditions, you will see a megakaryocyte engulfing a hematopoietic cell. So this is, I told you it's another cell engulfing another cell, but the cell inside that cell will be living and alive and it not killed. So here the megakaryocyte is the cell that engulfs the other hematopoietic cell. The engulfing cell is the megakaryocyte. So, and the engulfed cell can be any other cell, surrounding cell. So this happens in these conditions. But if a histiocyte is the engulfing cell, and it engulfs your inflammatory cells like lymphocytes and all. If a histiocyte engulfs surrounding inflammatory cells, this you will see only in Rosai-Dorfman disease. Very, very, very classical of Rosai-Dorfman disease. And histiocyte engulfing surrounding inflammatory cells. Very, very, very important. Megakaryocyte engulfing surrounding hematopoietic cells, it is seen in all the other conditions except Rosai-Dorfman disease. And histiocyte engulfing surrounding inflammatory cells is very characteristic of a Rosai-Dorfman disease. So these are some of the important things about that you have to know about your histiocytic and dendritic cell disorders. But final nutshell, maybe I'll take a 2 minutes more time where I can discuss on two other dendritic cell disorders, which are interstitial dendritic cell disorders. One is called juvenile xanthogranuloma, which I told already in the beginning, but I didn't discuss much. And second one, you have something called Erdheim-Chester disease. I wrote in the beginning, but you can go and look back the spelling actually. So that is Erdheim-Chester disease or ECD. So juvenile xanthogranuloma, typically they present in children less than 2 years of age, and they will have a solitary skin lesion. They will usually present with a solitary skin lesion. Since the name is xanthogranuloma like thing, so they will be yellowish in discoloration mostly, and it's like a mostly papule or a nodule in the skin. So that's how they come. And most common site will be in the head and neck, followed by the upper back, upper trunk. So this will be the common location. And obviously this can be diagnosed only by biopsy. You have to do a histopathologic examination by doing a biopsy. And if you see that CD11C negative, CD11C positive and CD1A negative dendritic cell lineage, then you can call it as interstitial dendritic cells, and that confirms the diagnosis. Only IHC, not only biopsy, even IHC also should be done to confirm that it's a juvenile xanthogranuloma and it's a histotic cell. And why it is called xanthogranuloma and why it is looking like this yellowish color, I told you, is because the histiocytic proliferation, histiocytes also will be appearing foamy in nature. They'll have a xanthogranulomatous transformation, like they will resemble Tauten giant cells also. So obviously, so this is what we call xantho. Xantho, the reason why they're yellowish and the reason why they're called xantho is because the histiocytes that are proliferating in this condition will be foamy. At the same time, they'll also be showing the characteristic interstitial dendritic cell type of IHC pattern. And Erdheim-Chester disease, and again, it is like a xanthogranuloma, but you will involve multiple systems. It's like a multi-system involvement multi-system involvement will be there, like in the skin, in the bone, in the orbit, in the retroorbital region, retroorbital soft tissue. In all these areas, you will be lesions that are similar to JXT, which means you will be seeing a xanthogranulomatous lesion in all these areas, multiple system involvement of xanthogranulomatous lesions. Single lesion JXG, multiple xanthogranulomatous lesion with the same histiocytic IHC, with the same foamy histiocytes seen in multiple different organ systems. That is what we refer to as Erdheim-Chester disease or ECD. And one catchy point is, I told you in LCH the bone lesions tend to be osteolytic. Here the bone lesions tend to be osteosclerotic. Bone lesions tend to be osteosclerotic. That's what you have to remember. Like simply how you will remember, a multiple myeloma bone lesions will be osteolytic, and a Poyen syndrome bone lesions will be osteosclerotic. Similarly here LCH bone lesions will be osteolytic, whereas your ECD, Erdheim-Chester disease bone lesions will be osteosclerotic. So that's the only maybe probably catchy important point. Maybe important, but apart from that there is nothing much important in this. The most important, if you ask me, is on the LCH, that is Langerhans listeocytosis. And the most important 2 points if you want to know: CD1A positivity and Bierbeck granules electron microscopy. And the current classification, most common thing involved in LCH is the bone, and you will have a punched out lytic lesions. Children may have skin lesions as a sole thing presenting to the physician, with probably a seborrheic dermatitis like presentation or eczema like presentation. So this all like are classic and stereotypical questions in the exam for a long time. So with this we are completing the histiocytic disorder. Then we'll be moving on to the principles of innate immunity and how these systems really work.